Good afternoon and good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, as well as the Africa Health Security and Sovereignty Agenda. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. We also have other technical colleagues on this call. And just to let you know that we have French translation on channel 2. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Margaret. Good morning, good afternoon, good evening for all the journalists, all the colleagues, all the partners who are joining this the press briefing of our Director General. We're pleased to take it and then to go through the different outbreaks, mpox, cholera, but also some other activities that Africa CDC is ongoing to make the continent safer and more sovereign. Thank you. Thank you. So, as mentioned, I'm pleased to take this press briefing on behalf of our Director General, Jean Cassier. Next slide. We'll start by this appreciation. Our Director General, His Excellency Dr. Jean Cassier, has been named to the DVIX 50 Power List. And as he mentioned, this recognition reflects Africa CDC's continued collaboration with AU member states, partners, journalists, to advance the Africa health security and sovereignty. So this work really strengthened health security and preparedness, building more resilient, self-reliant health system in the continent. So while we congratulate our Director General, we appreciate that there's still more to do for the continent on the way we respond to outbreaks, on the way we push the agenda of local manufacturing, on the way we push the agenda of digital transformation. And we believe that this year that has started will be an opportunity to accelerate the implementation of this vision and therefore having more of those recognition for our Director General, but also for the entire Africa CDC and mainly for the continent. Next slide. So the engagement has also been the opportunity to host the visit of His Excellency the Ambassador Galma Boru, who is the Ambassador of the Republic of Kenya to Ethiopia, but also the permanent representative of the AU and the United Nations Economic Commission for Africa. So the discussion that they have was really on the issue of strengthening collaboration between Kenya and Africa CDC to advance public health security and resilience across Africa. It's important to highlight that Kenya is the champion for the local manufacturing. And as you may also know, and you have been invited, journalists, to attend the AU summit that will be happening next week, Kenya will be hosting with Africa CDC side event on local manufacturing. And later on in April, there will also be an event organized by the president of Kenya, still on pushing the agenda of local manufacturing, which is one of the key pillars of the Africa health security and sovereignty. So our Director General really commend Kenya for the continued leadership and strong commitment to this new vision, especially on this pillar that we've mentioned that we'll be seeing next week, once again to the side event, and in April. We emphasize that because we really want the journalists and all the partners to get engaged, to get involved, and to know more about how the continent is trying to push that agenda. And it is cross-cutting. Whether we talk about mpox, following the lifted of the FX declaration, moving toward the control of mpox, we will need more vaccine to reach the herd immunity, to ensure that in countries that are endemic, populations that are exposed are vaccinated, which means we need larger dose of vaccine as even compared to what we've been using during this pandemic. And therefore, those vaccines will need to be produced locally. On the side of cholera, which will also be one of the important part of our debrief, you will see that the strategy that is being used currently when we respond to the outbreak is to provide one dose of vaccine to the population. And this dose that is provided during the outbreak is really to stop the spread of the disease. But we know that the protection of this vaccine with one dose is only about 1 maximum 2 years. Now, when we use the preventive strategy, which provide two doses, then we can have 3 to 5 years of protection. And this protection allow now the country to accelerate the investment on the WASH to ensure that the infrastructure are there, to ensure that they can increase the proportion of population having access to water. And those doses of vaccine, though the global production of cholera vaccine have increased, we're still below the 55 million doses that we might need as a continent. Therefore, it's also one of the key parts of that local manufacturing agenda. But beyond the vaccine, we also have the other medical countermeasure, we have the diagnostic tests, we have the drugs that are critically needed. Therefore, those different events under the leadership of our champion from Kenya are quite critical. And I thought it was important to take a bit pause to reemphasize how critical this visit was, how critical the side event will be, but also the event that will happen in April. Next slide. Now, to our public health event that we have in the continent. As you can see, comparing the same date in 2025 with January and 2026, we can see that this year we are having less outbreak than we did have last year. Whether we are talking about the high and very high risk event or even the moderate risk. This is also one of the most likely consequence of the capacity that country have strengthened in terms of preparedness, in terms of surveillance, in terms of early detection. Because when they have a low risk event, they can really stop it at the source. And therefore, we will continue to have less and less of those events. Though, on the other side, the impact of climate change, as you will see with Mozambique, the flooding and so on, tend to increase the number of epidemic and pandemic. So on one side, we have quite a number of drivers that are pushing to the increase of those events, but in the other side, strengthening health system through those epidemic, through those pandemic, also allow us to improve on how we have an early detection, but also a most efficient way of responding to those outbreaks. Next slide. So today we'll have some few good news. The first one is coming from Mauritania, where the official end of the Rift Valley fever has been declared on the 23rd of January. So the outbreak has lasted altogether 65 days, started in 26th of September and end on the 30th of December. But with a high case fatality rate of around 28.3%, but looking at the lesson learned, really the effort of the different partners supporting Mauritania, but also the system, has really pushed an important emphasis of enhanced surveillance, the active surveillance, the one we've been talking about more and more days and days as you've been following us, ensuring that within the community, the surveillance is happening, also considering the fact that this is zoonosis. The case management as well has been improved despite the high case fatality rate. It could have been worse, especially in the early stage, but the emphasis on case management and the community mobilization have also allowed the response to be extended, to be appreciated, and to be owned by the community, this with a strong leadership in terms of multi-sectorial coordination. Next slide. On the side of Mpox, we'll keep on talking about Mpox. As you remember, the facts have been lifted. We are moving toward a transition, the integration of Mpox in the routine of many countries. This week, there was a very nice article that we invite you to read that was published by the Director General of the NPHI in DRC and the Executive Director of WHO, Dr. Chikwe, on and remembering, alerting us that Mpox is not over. The fact has been lifted, but the mpox itself will continue. And therefore, we need to strengthen the country in that transition and also provide the tool that will be needed. And we'll come back when we talk about the vaccine. But as we do speak right now, the emphasis are in those 6 countries, DRC, Guinea, Madagascar, Liberia, Kenya, and Ghana, that accounted for 90% of the confirmed mpox case, but also others will come to them, Comoros, Cameroon, where we see a surge in the number of cases. Next slide. Coming back to Comoros, this morning we were having, during our meeting that you now know, every Thursday we have meeting with the country, the NPHI. We had today the Secretary General of the Ministry of Health, Dr. Mohamed, who was presenting the situation in Comoros. First thing first, we need to congratulate Comoros on their leadership in preparedness. Once they had the first case in Madagascar, Comoros was already engaging WHO, Africa CDC to ensure that they have the appropriate diagnostic, they implement the surveillance at the point of entry, which was done. So we really appreciate the work that has been done, especially in a country that is made of those 3 islands that you are seeing. And responding to an outbreak in an island is also quite complex as compared to what we can have in other countries. So it's a new experience that Comoros is facing, not only for them, but also for us on how we respond to outbreak in complex setting. And this is emphasized by a strong surveillance in the different islands, but also an important emphasis on the risk communication and community engagement for a disease that is new in those islands. So to date, 18 suspected cases, 10 has been confirmed, and they've been confirmed through the support received by the South-South partnership. We facilitate technicians from the INLB, from DSC, coming to Comoros to support in the training and ensuring that all was in place, which is very good. So now they have a strong laboratory, as they were mentioning today. The surveillance is also established, especially at the point of entry. They still need to emphasize on the surveillance because you can see that the ratio of contact to case is 1 to 6, while we will expect to have 1 to 20, but it's been put in place. At the point of entry, you will see that 3,000 people has been screened at the different port of entry, emphasizing the willingness of the country to really limit. So at this specific point of time, the support that we are working with Comoros is in terms of vaccination as well, to ensure that, yes, we control at the source, but also we plan for the vaccination in case the number of cases could escalate. So this support is bringing to the country, and hopefully at Madagascar that we'll see later, they will be having some allocation. Next slide. So talking about the neighboring country, Madagascar, the clade 1B is the one circulating. So far, we have 533 suspected cases. 214 have been confirmed, 0 deaths so far, which is also an important indicator of the strong case management that has been put in Madagascar. So now, when we look at the distribution, we have 20 out of the 114 health districts that have reported a confirmed case, especially on the side of Mahanja. So the local transmission is really linked to sexual workers. So when we are saying that, it's really for the epidemiologists, for the response to ensure that that population is well targeted and well supported. It's also critical to avoid the stigmatization, because if we don't avoid that, if a woman, for example, will now have mpox, then at home she will be considered as sexual workers, as we've seen in other countries. So it's quite critical for you, the journalist, to ensure that, yes, we provide the right information, but also let us make sure that we don't stigmatize a population. We really need to provide the adequate support to entire community. So as you can see, the number of cases has decreased, both in terms of suspected case and confirmed case, though the good indicator that is moving forward, test positivity, you can see that we are moving from 76.5 to 51%, which means that the number of positive patients are more and more coming from the community. We expect to be around 30%. So the support that we are going to provide will help. We believe that it will also support this response. Now, Madagascar has been allocated 30,000 doses of vaccine by the TSC, the Technical Review Committee. They are not yet in country, but the preparation in terms of communication, risk communication and community engagement are happening so that when the vaccine arrive, one, they target the right population, and two, the right information circulate, because you know all the issue of infodemia, which we don't want to happen. But also in terms of laboratory, they get all the support from the different partners to ensure that they have all what is needed. They receive 5,000 diagnostic, but also some kit to allow them to proceed with the sequencing. As you know, now at least 8% of all the positive cases need to be sequenced so that we can control, we can monitor the evolution of the different clade in the country. Next slide. Looking at the east part of the continent in Kenya, we are seeing that the stabilization of the situation. To date, we have been having 994 confirmed cases for 2,584 suspected cases. So now what is important is that the country is really pushing the strengthening of the active surveillance in Mombasa, Busia, and Nairobi that still account for the large majority of the confirmed case. Now, the challenge that the country is facing is in terms of vaccination. Yes, the 20,000 doses that were allocated actually reached the country, but the resource mobilization to ensure that the vaccine reach the target population is the key challenge that is happening at this point. So the different partners, the different actors are also looking for solutions for the domestic funding of those vaccinations, as other countries, Uganda, for example, has managed to mobilize domestic funding and vaccinate over 100,000 people. So I think Kenya will be doing the same thing, and we believe that the partnership will also be able to support the government effort. Next slide. Coming to the issue of vaccination, and I will take advantage to come back to our issue of local manufacturing. So far we have 5 million doses that has been delivered to 16 countries, and both the LC16 from Japan exclusively to DRC, and the 1.9 million of MVBN that has been delivered to the other countries, including DRC. So more than 2 million doses has been so far delivered. You will see in the next graph where are the remaining doses. Above 2.1 million persons vaccinated. Children also have accounted 26% of the total person vaccinated. And as mentioned previously, the shipment for 30,000 doses to Madagascar is being planned, while we are working very closely with Comoros, Cameroon, and also Mali for them to finalize the process, also to have the allocation of the vaccine and also be in the position to receive them in countries. Next slide. But there is a but. The vaccine are available. We still have 100,000 doses that are available for immediate allocation, which means in case any country has a challenge that now we have some doses that we might provide. However, those doses don't come with those operational funding costs. That cost is not the cost to transfer the vaccine to the country, but it's actually once the vaccine is in country, how do we bring that vaccine to the population? And taking the example of Comoros, if you have to move the vaccine to different islands, you need to take the plane. We need to bring also some of the expert in the field. It might be more expensive than if you have to do the vaccination in one capital city. So it's important to have to appreciate that complexity and that difference that our member states are facing. Yes, they have the vaccine. Yes, we provide the vaccine, but the challenge of operational funding is an important one. Now, we also have some device, over 700,000 devices that are available, and those ones are for the fractional dose strategy, which means instead of using one dose of vaccine for one patient, you can use one dose for five people in the community. And that's has been done previously in other countries. And we have some country in the continent, Kenya, Sierra Leone, Liberia, and others who are working on their implementation on that strategy. Those evidence are critical because they will also show that in the continent, we can use that kind of strategy. And as we move to the issue of herd immunity, this is quite critical. So now, pausing here a bit, you will see some of those countries, Kenya, Liberia, Zambia, South Africa, and Angola. I mentioned they do have the vaccine, but they have challenges to use them because of the operation for funding, but also a country like Angola, where there have not been any case in a while, it's quite a challenge to implement that vaccination. However, as we've moved to the lift of the facts for mpox. Now thinking about the controlling the mpox. This is where we will be moving on the preventive vaccination for mpox, as has been highlighted on the article that has mentioned, but many others where we see that it's how we want to control it on the long term. Therefore, we move to our agenda of local manufacturing, because looking at country like DSC, like CAR, and many other that has been exposed to mpox for a while, they will need much more dose to ensure that we reach the herd immunity when at least 60% of the population is immune and covered. So this is just another opportunity to reemphasize the importance of local manufacturing of vaccine and other medical countermeasures in the continent. Next slide. Now, moving to our issue of cholera, we can see that in the month of January, we had already 8,212 total cases. We had 138 deaths with a case fatality ratio of 1.7, knowing that our target is really to go below the 1%. We have 11 member states that are currently reporting. Now, this week we have Zimbabwe, which is one new country that has been reporting the cholera. We have five countries, South Sudan, DRC, Angola, and Nigeria, that contribute to almost 90% of the cholera case and around 85% of all the cholera deaths. Now, on the good side, we have Kenya that has officially declared the end of the cholera outbreak, and that will soon be leading to the after action review that will present soon. Next slide. As mentioned, Zimbabwe has been showing five new cases. And then when we look now at the country in terms of high burden, we can see DRC with 5,000 cases that has been reported in the last 3 weeks. And we have Mozambique as well. When the number of cases are increasing, we come back to Mozambique, which is also affected by flooding. And we have Zambia, where the percentage has been moving from 8 to 84, almost 1,000% increase in that change in that time. In terms of decline, we see that Angola, Somalia, Burundi, and Ethiopia have shown notable decrease, but the transmission continue. And once you have one case of cholera, it's still the outbreak, and this case can still spread in a different district, in a different province, and of course in the different countries. Next slide. Coming to Zimbabwe, where 5 cases of cholera has been reported with one death, which made a very high case fatality rate of 20%, emphasizing the need to have a quick response, but 20% also because the number are very, very, very small. So when we look at the index case, is a 38 years old, a male which developed diarrhea and vomiting and recently returned for Mozambique. We'll come back to Mozambique and also emphasize the challenge of cross-border collaboration and coordination. So the last outbreak in Zimbabwe was in 2024 and then 2025. And the hotspot that has been issued, you can see the red sign on the top, is around Zenga community coming from Mozambique, moving to moving to Zimbabwe. So the driver remained the same: poor sanitation, cross-border movement, population density, and flooding that we now see in Zimbabwe, in Mozambique, in that part of the continent. So the response is being implemented with the establishment of the cholera treatment unit, the enhanced in risk communication and community engagement, but also the surveillance that is critical to ensure that we can capture the case in the community and then take them to the hospital, but also identify the hotspot. And in those hotspots, that where the different sites for clean water are implemented. Next slide. In DRC, we see a small decrease in the number of cases and also in the number of deaths. But as mentioned, DRC remains the country with the highest burden of cholera. So gladly, we will have the cholera interaction review, the continental one that will happen in DRC, and that will be followed by the interaction review of the country itself, which will be learned from that experience. So really pause and think. The context is quite challenging. We have the conflict, we have the displacement, we have the seasonal flooding. But also at this point, what can we do now differently to what has been done previously? One thing already, as already mentioned, is to bring the attention at the highest level, at the political level, and the establishment of the presidential task force to ensure that all the different ministry will be involved is quite critical. But now, in terms of challenge, you can see the different, depending on the provinces, the artisanal mining in the Tropo. You can also see in Kinshasa, the capital, the lack of access to water in those slums are also drivers on spreading the cholera within that province of Kinshasa. In other parts, like in the Kivus, we have the population movement. And of course, we still have that insecurity. And that insecurity is also pushing the population to migrate to Burundi, where we've also been having some cases of cholera coming from DRC. Next slide. Now, going to Burundi, that I was just mentioned, gladly, we have been seeing a decrease in the number of cases. Now we have a slight increase this week. The case fatality ratio remain at below the 1%, 0.4, with 14 deaths out of 307 and 92 cases. The challenge of access to water remain critical, but lots of effort are being put in place to increase the access. And the discussion around the vaccine is also happening so that the country has the opportunity and the time to strengthen the WASH, the infrastructure, while they protect the population. Remember, one dose can protect between 1 and 2 years, and two doses can protect between 3 to 5 years. So in 5 years, you really have the time to really address the water infrastructure aligned with the hotspots that are defined by the cholera endemicity or risk of exposure. Next slide. The cholera outbreak in Mozambique. So far, we've been having 71 deaths out of 6,068 suspected cases. Most of them are female. As you can see, the male are representing 49.9%. We have the children less than 15 at 13%. Now, when we look at the hotspot, Nampula, Tete Province, and Cabo Delgado Province, we've been talking about Zimbabwe, talking now about Mozambique. We talked previously about Zambia, which also emphasize one critical point that I will mention before concluding on the issue of cholera. Next slide. So Kenya declared the end of the outbreak. That happened on the 27th, which was a really important response. And the lesson learned was really on the side of the active surveillance that has been implemented, but also the emphasis on access to water. Now, the after action review that they will conduct will really see how that response can be sustained. What are the critical components that need to be emphasized by the government itself instead of access to water, long time instead of access to water, but also on appreciating how the capacity has been of response has been expanded, especially in Nara Country, Migori, and also Nairobi, which has been the hotspot of cholera. Now, when you look at this is the good news. Kenya declaring the end of the outbreak. We also mentioned that Chad did the same at the end of December. But on the other side, we are mentioning Malawi, Zimbabwe, Zambia, and all those countries that are having a case which are also lead to connected to the flooding. And this emphasizes one of the critical actions that we as IMST, Africa CDC, WHO are really pushing is the issue of cross-border coordination. Because if you implement a vaccination for cholera in Mozambique and you don't do it at the same time on the neighboring countries, by the time the outbreak starts on end in one country, it will move to the other one and vice versa. So this also emphasizes the importance of that coordination, but also on getting more available dose of vaccine locally produced so that we can be in a better and stronger position to ensure that the different countries has the prevention and therefore can invest on the infrastructure. Next slide. Now, to summarize, we have Mpox, the recent outbreak surge that we've highlighted in Madagascar, Mali, Cameroon, Comoros, that requires sustained vigilance despite the lifted of the effects. We have those 6 countries, Guinea, DRC, Liberia, Madagascar, Kenya, and Ghana, that account for 91% of the case. We agree that at this point, and the support that we are bringing to country, vaccination remains central to the response, but also to the long-term control of Mpox. It is critical. We will assess, provide the information of the estimate number of population that might need those vaccines so that we can also have a clear demand that we push the agenda of local manufacturing. And that will be part of the discussion that will happen at the end of this month in Kinshasa during the after-action review of cholera, but also including the interaction review for cholera to have that discussion on what have we learned. And what have we learned from that is this platform, the IMST. But what is the next phase of the IMST? This is a platform dedicated to response to outbreak. But you've seen now we are talking about prevention to cholera. How do we integrate cholera within prevention within that platform? But also other disease. We have many other diseases that will benefit to this type of platform. On the side of cholera, DRC continued to report the highest weekly case load, followed by Mozambique, where flooding is also a compounding transition risk. We've talked about the new outbreak in Zimbabwe and emphasized the issue of cross-border coordination because we see that those different countries in the southern part of the continent are being affected more or less at the same time. So the strategy should not be focused to one country, but really to see at the region with our different partners how we can address them. Happily, Kenya has declared the end of its outbreak and will be followed after action review, while the IMST will do the same at the end of this month to see what should we do different and move forward to have the control and move toward the end of cholera by 2030 as the GTFCC, the global agenda for cholera elimination, is set. With that, I'll be happy to take some questions for the audience, and we have also our colleagues who are connected and that will be happy to respond to any question. Thank you.
Thank you, Prof. Let's cross over. I have 2 questions here on the chat group. We have one from Loazi of North Coast Radio. The question is, what developments are there for Africa's pooled procurement strategy in the acquisition of medicines for pandemic preparedness? That is the first question. And then the second one is from Oboiko from the Kenya Broadcasting Corporation. The Abuja Declaration on Health 2001 was a commitment by Africa Union member states to allocate at least 15% of their annual national budgets to the health sector. 25 years later, we have not met this commitment. What is the way out? You can take those first 2. I think the second one might be appropriate for Dr. Landry, if I'm not wrong. So back to you, Prof.
Yes. Yes, thank you. Definitely the second one on the Abuja Declaration and the link to the Lusaka agenda, definitely Dr. Landry is the best for that. So the pool procurement strategy, you remember that we have the two countries, Namibia at some point and Botswana, that we were really challenged by the increase price of some of the most critical medical countermeasure. And that was also a good opportunity for us to re-emphasize the need for this pool procurement, which is moving forward. And this pool procurement is one of the elements of the local manufacturing agenda, because when we manufacture locally, then we also have that group of people, that number of countries, that billion of people that will now be able to have access to that market. And this is a key part of the roundtable that will happen on the side event, sorry, that will happen next week. So we'll be happy the week after to come back and to give you a clear outline on what's the way forward for those different mechanisms moving forward. So maybe I will now give to Landry on the issue of the Abuja stroke Lusaka.
Thank you so much, Professor Yap, and thank you to our journalist from Kenya. Yes, the issue of financing our health sector on the continent has always been, I would say, a challenge when looking at the allocation over the years from our domestic budget to the health sector. Despite the commitment taken in Abuja to allocate up to 15%, based on the recent data, only 7 countries on the continent were able to reach that threshold. But beside that, what happened recently globally with the reduction of the official, the ODA, official rural assistance toward the health sector on the continent, was a wake-up call to our leaders, a wake-up call to our national health sector. And that led to our head of state last year calling on Africa CDC to rethink how to finance health on the continent. I think what I can share at this point is, first of all, I would like to invite you to go through the Africa CDC Green Book, which was published last year. And there's also a recent publication that was shared by Africa CDC Director General 2 days ago, I think, Margaret, on how to finance the Africa health security and sovereignty. I think this is important that we invite the journalists to go through these 2 documents to understand that there's a clear vision from Africa CDC, guided by our head of state, the champion for domestic financing, His Excellency President Kagame, is really guiding the direction of travel in that regard. They are basically around the Green Book, 3 critical direction of travels that the continent is taking to improve allocation of resources towards the health sector. The first one is, of course, trying to achieve the 15% as defined by the Abuja Declaration. But that first pillar is constrained by the fiscal space. As you understand, our countries are still grappling with the debt crisis. And then the second pillar is the innovative financing, which will now look into a different way of taxation. I think you may recall the tax on air ticket, the tax on importation of the sin tax, importation of goods like tobacco, on alcohol, which can also be allocated towards the health sector. The diaspora bond is also another innovative financing that is well captured in that second pillar. And then the third pillar is the blended financing, which will now tap into the private sector to look into the health sector as an investment. I think Dr. Ya was talking about local manufacturing, and there's also the area of digitalization in the health sector, which really call for the private sector to invest and to do business. I think across those 3 pillars, there are what we call the cross-sectoral let's call them the cross-cutting strategies. Because at the end of the day, before we achieve those first three pillars, we can really secure some efficiency gains through good governance, efficiency gains through transparency and accountability, and efficiency gains through mechanisms that leverage the power of digitalization. I think these are important points that I wanted to share and with regard to that question. Thank you.
Thank you very much. Dr. Landry is our Director of Primary Healthcare. We now cross over back to the floor. We have Helen Branswell from START. Helen, you have the floor.
Hi, thank you very much for doing this and for taking my question. I wanted to ask about the hepatitis B birth dose study that is supposed to be conducted in Guinea-Bissau. Has Africa CDC heard anything new from either the Bandem Health Project or from health authorities in Guinea-Bissau about the status of that trial? Have you seen a new protocol? Are you involved at all in any way in helping to shape the protocol for that study? Thank you.
Thank you very much, Helen. Let's take the next one before Prof comes in. We have Paul from Lancet. Paul, you have the floor.
Can you hear me?
Yes, we can hear you. Go ahead.
Yes, thank you very much for taking my question. So I want, if you look at the end of the declaration of the end of Mpox outbreak, I know you made conscious efforts to communicate that this end doesn't mean that there are no new cases, but does the general public, how was this conveyed to the general public that actually cases are actually happening? And like you mentioned in this press release, the addition of a new country to the outbreak. So what are the measures being taken to ensure that the general public understand that that is not the end of the of cases? And in sharp contrast, when the Marburg outbreak was declared ended, it simply meant that the country had not reported new cases for a particular period of time. So what is being done, or how is the concern being addressed that for some outbreaks it means that no new cases, while for some outbreaks it simply means that no, there are still some cases elsewhere? And I've also been realizing that we are not talking a lot again regarding issues around of public health importance, issues around patient zero, how these outbreaks began. It seems as if the priority now seems to be getting the outbreak under control and moving to the next one. So what are your concerns about tracking the source and the end of these cases such that we are not having issues around silent reservoirs within a short period of time that could lead to new infections? Thank you very much.
Thank you, Paul. Back to you, Prof.
Thank you so much, Paul. I really hope that next week we'll have some of you at around the AU Summit so that we can have some of those engagement that our DG has really emphasized, so that you know a bit more than the short term that we have. So I will let Dr. Mercy start the response to the question of Paul on the difference between when an outbreak is over in one country as compared to globally, but also the issue of protracted outbreak and also the issue of One Health and how we get back to the patient zero and to the reservoir. Now, the question of Ellen on the hepatitis B study. So at this point, we are still monitoring the conversation with the countries. And so far, there has been nothing really new on that side. So as soon as we have something new, we will let you know maybe during the next thing. But what we know is that the critical need for the country is really hepatitis. As you remember, when the minister himself was there, he was highlighting that 1 out of 5 population is affected by hepatitis. That is quite important. So over to you, Mercy.
Thank you so much, Prof, and thank you, Paul, for that very important question. So in the space of epidemiology, we have different concepts, and I'm happy that you've rightfully mentioned some of them. And one of it is the index case. It's really critical towards understanding the source of exposure. As you would know, some countries really have built very robust systems to be able to pick patient zero, as you call it, or the index case, and are able to understand the source, and which we do have information for. Some of these cases, at the onset, you would see they are linked to travel history, though they have travel history, while in other as instances, there's always an index zero, but sometimes are missed, and that really shows some of the gaps in surveillance. In some cases, where we find it's really very sensitive to give details about patient zero, sometimes we don't give that information out because it has some implications in terms of cross-border issues and all that. But not necessarily that the information is not there. The information is usually there for most part of it. In the situation where we're looking at mpox, to be more specific, we all know that for countries that had not been reporting cases or are not endemic to the disease, the patient zero usually has a travel history. But should we stop there and cry foul that case move? Because we can't stop people from moving. We can't stop goods and services from being transported. And that is why the IHR was institutionalized, to ensure that we are able to build up very resilient health systems that are able to detect and stop the outbreaks at its source. That's not in any way saying that it cannot come up. It definitely will be having diseases because the world is that way, and we are encroaching into the animal space. That's why we're having zoonotic spillover. But we have to put up systems that are able to detect and stop these outbreaks from spreading. And I'm happy that several countries have been able to mount those early warning systems. WHO, in Africa CDC, in collaboration with WHO, has also put up systems like the epidemic intelligence from open sources that is also helping us track signals early enough and have them detected. In terms of looking at when the outbreak is declared over, and then we still have cases here and there, for protracted outbreaks, you can't continue to call it an outbreak. For instance, we know that the COVID-19, we still have sporadic cases here and there, but we need to set up a threshold because the system cannot be on outbreak mode throughout when we have countermeasures that are able to keep it under check. So what am I saying? For instance, something like malaria, where we already know that we have the vector in place, but we also have therapeutics that are also approved for malaria. We have a particular threshold that we've in any country that is endemic that we know this is as usual. When that exceeds that threshold, that's when it's been declared an outbreak. In the case of mpox, we know that a new clade was introduced, which was a clade 1B. That was one of the reasons why effects was announced. Of course, not only so, because we also saw that there was also an increase in the cases of clade 1A, which of course is zoonotic in nature. But what we are trying to say now is that we have had a protraction of mpox for quite a while. And as epidemiologists, we already know that our knowledge in terms of clinical management has improved. We already know the risk groups for the clade 1B, and we already know that if we mount our control measures and target these risk groups, we are also going to keep it under check. And so one of the things that we are doing is to set thresholds in the next surveillance strategy that will be published through the IMST, will have those guidance for member states, so that for countries that are endemic or have been having protracted outbreak, they are able to also calculate their threshold and understand that if it exceeds this, then that's when it's declared an outbreak. For countries that have never reported before, of course, a single case would be declared an outbreak, but you will not expect a country that has mpox in the wildlife, like DRC, to declare a single case of clade 1A as an outbreak. Definitely, it's not going to be the case. So we have threshold, and different countries with different contexts would be adopting as appropriate. Thank you.
Prof, you're on mute.
Thank you. Just to highlight that the vision of Africa Leads So the country are the one leading. Therefore, Paul, when the outbreak is now the country level, they will be the one to continue to engage the population as we continue here in that platform to talk about mpox, because definitely it's not over. And then we coordinate when we feel that it escalates the level of a country. Over to you, Margaret.
Yes, thank you. Let's cross back to the floor. We have Esther Nakazi, a health and science journalist from Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Prof. I hope you can hear me. My internet is a bit erratic.
Yes, we can.
My first question is on the outbreak of mpox in islands like Comoro and Madagascar. I just want to understand, I know you talked about it, but I want to know the challenges that you are facing in managing these outbreaks. And secondly, is it the first time that you are doing this in an island as Africa CDC? Is the IMST cognizant of this issue in your way of dealing with it, because it plays out differently? And then secondly, in terms of cholera, how are you advising member states to respond in conflict situations, especially in countries like Sudan? And you talked about 2 doses. Are we, going rather routine immunization? Are we getting into the policy of of doing this as a policy for cholera for all the countries, putting it in routine immunization programs for the countries? Thank you so much.
Thank you, Esther. Back to you, Prof.
Thank you, Esther. I think we will also take a bit from Dr. Messi on the mpox in the island, and also Dr. Landry on the routine, because you are asking how do we move from the 1 dose, which is the response to outbreak, and then the 2 dose, which is routine. We can start with Dr. Messi.
Thank you, Prof. I think there was an ongoing rehabilitation work going on in my office, so there's some background noise. Apologies for that. But in terms of some of the challenges that the islands are facing, definitely, as you all know, the islands are very, very attractive touristic sites for so many of us and for so many people. So they're quite attractive for tourism and all. That also increases the vulnerability of the islands in also importing some of these diseases. But I remember when Prof was presenting, he said something. When Madagascar reported, Comoros had begun already looking at mobilizing vaccines, putting in place preventive measures, putting in place or heightening its surveillance strategies. So definitely, I will not say they are really so challenged in managing the outbreak. We think they are really putting in place stringent measures to be able to curb the outbreak. But it is the very first time of the country as well to report mpox. I'm talking about Comoros. And so we are not also expecting that they have the history of management like other countries that have been dealing with it. And that is the beauty of the IMST. Now we are sending experts that have managed the outbreak in different countries to Comoros so that they can also share the experiences. And I think WHO deployed teams that have also supported other countries to support the government. So this is where we come in with a joint force to ensure that we can share best practices and thereby improving on their response. I would end there and I give it back to you, Prof.
Yes, thank you, Mercy. And also on the actual challenge, logistical challenge for the response, the Secretary General this morning was emphasizing that while in many countries you can have the road that can be used to transport medical countermeasure and so on, there they will only use the plane, and the plane are not that many, which means the cost of actually implementing one activity would be more important in that environment as compared to many other countries where you have a better and larger means of transportation. Dr. Landry?
Yes, I think the question was about how do we move the mpox vaccination into routine immunization, right?
No, actually, the cholera,
Oh,
the two dose.
okay. Yeah, I think the fundamental factors around moving into routine immunization is not only around access to the commodity. We have to ensure that we have sufficient doses to meet the needs of the population. And the second one is the risk group. I think we have a clear understanding of the epidemiology of cholera on the continent, and there's a set of countries. I think Dr. Ya was talking about the outbreak in the central and southern and eastern part of the continent, where we can definitely think about how to integrate cholera in those high-risk community cholera vaccines into the routine program. Then the third point is definitely the local manufacturing. And I want to again come back to what Dr. Yap mentioned. During this summit, the summit coming up next week in Addis Ababa, there's going to be a lot of discussions around local manufacturing of vaccines on the continent. And cholera is one of those vaccines that we think we need to have enough capacity, enough volume on the continent to be able to have this as part of preventive vaccination around periods of outbreaks. And linked to that is the financing. At the end of the day, routinization is also about how do we finance our vaccination program. We have currently significant support from programs like the Gavi. But when it comes to the package of vaccines that Gavi can support for eligible countries on a routine basis, there's a limit to that. And if we want to add cholera vaccine as part of the routine, some countries will have to also look into how to domestically finance those programs. So those are the parameters that I would like to add on the table as we think about moving emergency vaccines into routine programs. Thank you.
Thank you, Landy. There is one question from Esther on the how we can support countries in responding in conflict or complex environment. So we mentioned to you in November, December that we were bringing a new member on board within the IMST, which is the APORA. APORA is the humanitarian military. So those are professional on how they respond in those specific settings. So an MOU will be signed with Africa CDC. They will be part of the IMST, and then we will learn from each other on how we maneuver in those specific environment. And the APORA is a network of all African countries, expert in medicine, in humanitarian response. So that is one addition of this platform in the diversity to respond in those very complex environments. Over to
Let's
you.
take the next question. Thank you, Prof. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. Good afternoon, everybody. I wanted to speak about the relations or agreement between African countries and the U.S. government. I know there are several countries that have signed this bilateral agreement, but also the African CDC is also discussing with the U.S. government. But between the African countries and the U.S. government, there have been concerns about these agreements. And one main one that has come out in some countries, for instance, in Kenya, where there was a court ruling, is data protection. I want to know if this is something that has come up in one of your discussions between Africa CDC and African countries, and generally if it is a concern, and what you will advise with regards to that and any other concerns. Thank you.
Thank you. Let's take the last one before the response. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Hi, thank you so much for doing this as always. I wanted to ask about the U.S. demand to Gavi, but that influences many of the vaccines used throughout Africa to remove the preservative thimerosal over concerns that RFK Jr. has about mercury. I wanted to see if Africa CDC has a stance or a concern about this. My understanding is it's mostly used in multi-dose vials, which are common for immunization days and weeks that happen in Africa. Thank you very much.
Thank you. Back to you, Prof.
Okay, I was seeing the hand of Paul. Maybe we can take that one as the last.
Right. Paul, you have the floor. I didn't see the hand.
Thank you very much. So a quick question I want to ask is, I know we always talk a lot about how African governments are committed to honing their healthcare systems. In recently, a couple of weeks now, we are seeing what their funding priorities would be in their health budgets. So what is Africa CDC's perception and view regarding how African governments are prioritizing health in their national budget, and what that says regarding what they are actually telling the organization about their readiness to hone their health sector, in considering the challenges coming from other major funding sources. So what are your thoughts on the current priorities of African governments regarding their health budgets?
Okay, thank you. So, yes, I will take the question from Paul, and I will let Dr. Mercy handle the issue of data protection on the line of the data sharing agreement that Africa CDC is putting in place with the different countries. And then for the question of Gabriel, there is a Landry was connected, but also Mosoka was leading the research and innovation. They can also support. So for the question, Paul, this is a very important question on how we look at the issue of budgeting and so on. Two things. First is, you remember Africa CDC decided to deploy finance technical officer in 16 member states, 16 to 20 member states. And the plan for those one is to be seated at the Ministry of Health and to make the link and the bridge with the Minister of Finance, so that we ensure that there is that conversation really happening, bringing the health as a top priority, but also ensuring that that mechanism of financing is well considered. The second point, which is more present, I will say next week, there is a side event of financing where Africa CDC is conveying the Minister of Health, of course, but also the Minister of Finance from all our member states. And the discussion will be around how do we move forward on ensuring that the health is a critical component of the domestic financing. So if you are in Addis, that would be good. If not, the week after, we'll come back to you with those answers. Maybe we can move with Mercy and then Landry or Mosoka.
Thank you, Prof. And thanks so much for that question. And it's also important for us to understand that while Africa CDC is not prescriptive, we also have direct agreements with the member states. Of course, the head of states are those that have established the statute of the Africa CDC, which also mandated member states to share information with Africa CDC so that to permit Africa CDC to be able to achieve its overall objective of securing the health of the African population. So we have developed a very robust data sharing framework that would also guide member states on what they will be sharing with Africa CDC. And in terms of data protection, globally, we know about the pandemic agreement, and within it, we had the pathogen access and benefit sharing system that is also a very crucial component that we know that whatever member states are signing, bilaterally, they are also taking into consideration some of these different global guiding documents. But on our side, we have also a very structured system in place where the data that member states are already sharing are being, analyzed, as well as helping Africa CDC to to be able to carry out this mandate, both in planning, in strategy, as well as in response. We also have some sort of a new data center that we have established. Of course, it's still work in progress, and that we are hoping that before the end of this year, we should also have a very, very robust analytic center at the Africa CDC that will really permit us to have deep dive in terms of the data that countries are sharing with us. So with those, I think we have on our website some of the documents that we've published that serve as policy, the health information exchange policy and standards that also serve as a guide for countries to be able to share their data, both with Africa CDC and other stakeholders around the globe. Over.
Thank you, Mercy. So, Dr. Landry, do you want to start on the question on the immunization?
Yeah, I don't know whether Dr. Musoka would like to take that one.
Thank you so much, Dr. Landry. So the issue of the thimerosal that is used, mercury-derived product to sort of in multi-valve vaccine has come up as a condition. And I think the response from Gavi has been they will respond and we need to look at the science. So we hold our science as we go through the science and get back to respond to that question. They've acknowledged the condition set by the secretary, and they said they have recognized it, and we'll consult internally and be able to respond. But it's two sides of the coin, the issue of the presence of mercury and the long-term use. So it's something that we'll get back as we review the science together. Thank you.
Thank you very much, Dr. Fala. Thank you, Prof. Yap, as well as Dr. Landry. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you, Prof, for your closing remarks.
Thank you so much once again for being there, being with us, following us, making us accountable to the different action and activity that we are implementing across the continent. So next week will be a critical week for not only Africa CDC, but for the continent. The African Union Summit will take place in Addis. And on the side, we have a three-side event on the local manufacturing, financing, and also ensure how we move the agenda of preparedness and prevention to outbreaks in the continent. So we look forward to be with you next week. We'll provide you some of the new information that will occur. In the meantime, support us on sending the right information to our communities and our leaders. Thank you, and have a nice afternoon, evening, or morning, wherever you are. Thank you.